So we spoke about the curative intent and curative surgery, transplant, ablation, but understandably, want to make sure that we pass the message to our patients. It's not like that's the end of the world if really it's not resectable or it's not cured, or at the same time if it occurs. We have a lot of potential and opportunities to try to continue to treat. And I'll start first with the embolization. So please tell us, Amit, whom do you treat embolization? Which patient? What's the state of the disease there?
Yeah, Ghassan, I think the first point is very important, that just because a patient may not be eligible for curative procedures, surgical resection, transplant, or ablation, there still can be a significant improvement in survival with our other therapies. So embolization is a procedure where we take advantage of the fact that the liver cancer has a unique blood supply compared to the background liver. Liver cancer typically gets its blood supply from branches of the hepatic artery, whereas the background liver gets its blood supply from another blood vessel, the portal vein. So embolization involves putting a catheter through the groin, following the blood vessel up to that cancer via the hepatic artery, and injecting small beads with either chemotherapy or radiation therapy directly into the cancer. And so that's called chemoembolization if it has chemotherapy. It's called radioembolization if it has radiation therapy. And there are some sites that actually do the beads without either, and that's called bland embolization. And by doing so, you have two different mechanisms of effect. The first is those beads actually go in and they can block the blood supply to the cancer and starve it of its blood and other nutrients it's trying to get from the blood, including oxygen, and thereby cause that cancer to start to die and shrink in size. If the beads are embedded with chemotherapy or radiation therapy, that chemotherapy or radiation can also be emitted within the tumor and thereby also augment that cell death by either the chemotherapy or radiation therapy. And this is particularly important actually with that radioembolization, where the internal radiation therapy can be emitted over several weeks to months and cause a high degree of cancer death by the radiation over time. This procedure is very well tolerated and, once again, can cause notable decreases in the size of the cancer spot and significantly improve survival, although in many cases is typically not regarded as curative as the other procedures that we talked about previously. These therapies are largely restricted to patients who are not amenable to these curative procedures but have cancer restricted to the liver. But they are also used as a bridge to liver transplantation. So one of the other main areas that we use this are patients that are listed for liver transplantation that have to wait for several months prior to an organ becoming available. And so we often use these embolization procedures, quote unquote, as a bridge. So you use this to control the cancer while you're waiting for that liver transplant to occur. So, once again, very effective therapies for these patients with liver localized disease.